Hello and welcome to another session of Next Saviours Essential Question Series NEET PG 2025. Today we are going to have a discussion on how to diagnose the questions related to congenital septal defects in the heart. Because if you look at this question, sample question over here, a 2-year-old child presents with the episodes of cyanosis that improves when the child squats. By the time you reach this line, you already know that you are talking about the question related to tetralogy of Fallot. On examination, the harsh systolic ejection murmur is heard at the left upper sternal border. So you are confirmed that you are talking about the question related to the tetralogy of Fallot. But the problem is that when you look at the options, nowhere the TOF is mentioned in the question. Rather, they are asking about the pathophysiological mechanisms. And this raises the concern because despite knowing everything related to this question, we get stuck in order to mark the answer. So to help you out, we are going to talk about the four septal defects and how these questions could be framed in your examinations. The first one is the ventricular septal defect. The second one, the tetralogy of Fallot. The third one is the patent ductus arteriosus. And the fourth one is the atrial septal defect. How these questions are framed, one by one, we'll be talking about by understanding the basic pathophysiological mechanism. So, first one is the ventricular septal defect. Now, all of us are aware of the fact that ventricular septal defect is the opening in the interventricular septum, allowing blood to shunt from the left ventricle to the right ventricle. So, this left to right ventricle shunting of the blood happens because the left ventricular pressure is higher in comparison to the right ventricle during the systole. Now, what happens is that this oxygenated blood it moves from the left ventricle into the right ventricle, and there is always a possibility of the increased pulmonary blood flow because of this. Now, this pulmonary over circulation, that means pulmonary congestion or pulmonary over circulation, it results in pulmonary hypertension due to increased volume and pressure in the pulmonary arteries, as a result of which the left atrial and left ventricular volume overload due to return of excessive pulmonary blood. So this continuous process over a period of time might result in complications, and one of the complication is congestive heart failure. Why? Because of increased pulmonary blood flow consistently leads to left-sided heart failure, identified as the features of tachypnea, the poor feeding, or hepatomegaly. On the other hand, now, if the pulmonary vascular resistance it goes on increasing for a long duration of time, there is a possibility of the reversal of this shunt from the right to the left side. So, as a result of which there is deoxygenated blood which is moving from the right to the left side. So, this type of shunting is known as Eisenmenger syndrome. That means right to the left shunt, which develops over a period of time because of increased pulmonary resistance, and it results in the features of cyanosis late in the course of the disease. So this is the pathophysiological mechanism for ventricular septal defect. Let's see the clinical features. If the ventricular septal defect is restrictive type, that means small, having size of less than 3 millimeters, then it will be asymptomatic in majority of the cases. It will be having normal growth and development. But one thing which remains persistently available to identify is the presence of loud, harsh, hollow systolic murmur at the left lower sternal border. On the other hand, when the ventricular septal defects are large, that means more than 6 millimeters in size. So in early phase, before the development of the pulmonary hypertension, there will be features of the cardiac failure. But in late phases, where there is reversal of the blood flow, that means from right to left shunting is there, identified as Eisenmenger syndrome, there will be features of cyanosis and clubbing, polycythemia because of hypoxemia, and loud P2 sound due to pulmonary hypertension. So these are going to be the features in case of ventricular septal defect. Now, what is in between happening when the size of the ventricular septal defect is moderately large, that means 4 to 6 millimeters, then in that case, the patient would be having a failure to thrive, recurrent respiratory infections, tachypnea, excessive sweating, particularly during feeding, and the presence of the same murmur, that is harsh hollow systolic murmur at the left lower sternal border. So these are the features for the ventricular septal defect. As far as the murmurs are present, we have already talked about it is harsh hollow systolic murmur, which is best heard at left lower sternal border. So these are the features which will always be provided to you in the question in order to mark the correct answer related to this one. Then the X-ray findings are that in VSD there is going to be a cardiomegaly with increased vascular markings and the left atrial enlargement. On the echocardiography, you can very clearly identify that there will be a direct visualization of the defect in the interventricular septum with a left to right shunt, and this is confirmatory for ventricular septal defects. So let's see how the questions are asked in this particular scenario. You can very clearly identify a 2-month-old infant brought to a pediatrician with a complaint of poor feeding, excessive sweating during feed, and recurrent respiratory infection. On examination, there is a loud, harsh, hollow systolic murmur which is best heard at the left lower sternal border. Now you can very clearly or easily identify that what is the topic we are talking about. And echocardiography reveals left to right shunt. That means it is still in the earlier phases. So, which of the following is the most likely diagnosis? The classical murmur of the VSD is harsh holosystolic and it is best heard at the left lower sternal border. Symptoms of left to right shunting are present like poor feeding, the excessive sweating, and recurrent chest infections. Echocardiography is further confirmatory of left to right shunt. So, VSD is the most probable answer for this particular question. Coming on to the next topic, which is tetralogy of Fallot. You know, TOF is a cyanotic congenital heart disease which is caused by four major defects. What are those? The first one is the ventricular septal defect. Second is the right ventricular outflow tract obstruction leading to pulmonary stenosis. The third one is the right ventricular hypertrophy. And the fourth one is the overriding of the aorta. Now, what happens as a pathophysiological mechanism? That the primary problem in case of Fallot's tetralogy is RVOT obstruction. That means right ventricular outflow tract obstruction, that is pulmonary stenosis. So it causes the increase in the pressures of the right ventricle, which results in the deoxygenated blood shunt from right to the left side across the ventricular septal defect. So this right to left shunting, it results in cyanosis, as we already are aware of. This results in cyanosis because the deoxygenated blood, it enters the systemic circulation. One more important finding related to this tetralogy of Fallot is the TET spell, which is paroxysmal hypercyanotic episodes that we are going to talk about when we will talk about the clinical features. But hopefully the pathophysiological mechanism is identified. And one very peculiar thing related to TOF is the early cyanosis. That means this is not a late feature as we have witnessed in case of VSD. It is early cyanosis that happens. Now, as far as the clinical features related to this TOF is concerned, it will be presenting with cyanosis because of right to left shunting across the ventricular septal defect. It will be presenting with clubbing as it is seen in untreated older children because of chronic hypoxia. The polycythemia is because of increased RBC production in response to hypoxia. Dyspnea on exertion is due to reduced oxygenation. And now the TET spells, which are hypercyanotic spells. These are the episodes of sudden cyanosis, dyspnea, irritability, loss of consciousness due to a sudden increase in right to left shunting. You know, one very important finding in the tetralogy of Fallot is that there is an improvement of symptoms by squatting. Why? Because it increases the systemic vascular resistance and thereby reducing the right to left shunt. So squatting position is responsible for declining the or improving the symptoms. As far as the murmurs related to this TOF are concerned, there will be a harsh systolic ejection murmur which is best heard at the left upper sternal border. And there is also a possibility of single S2 sound due to severe pulmonary stenosis preventing closure of the pulmonary valve. So these are the murmurs on the basis of which you will identify the question. Now, very clearly, you can easily identify on the basis of the X-ray findings that there will be a provision of a boot-shaped heart and decreased pulmonary vascularity. So on this basis, you can easily identify that we are dealing with the X-rays of TOF. And finally, echo findings would be the defining findings of the TOF, like overriding aorta, right ventricular hypertrophy, VSD, and pulmonary stenosis. So let's see the question now. That a 2-year-old child presents with the episode of cyanosis that improves when the child squats. Now, you can very easily identify that it is a question related to TOF as we have taught in the beginning of the lecture. On examination, a harsh systolic ejection murmur is heard at the left upper sternal border. Now, which is the primary pathophysiological mechanism causing cyanosis in this child? And you know that if we go option by option, the first one is left to right shunting at the ventricular level. In TOF, shunting is typically right to left, not the left to right. Then the second one is right ventricular outflow tract obstruction. Now, is the key determinant of cyanosis, which is present over here in the question. Now, it restricts the blood flow to the lungs, forcing more deoxygenated blood to bypass the lung and enter the systemic circulation via VSD, thereby causing hypoxia. Now, as we already have talked about that these kind of the children, they often squat because it increases systemic vascular resistance, thereby reducing right to left shunt and improves pulmonary blood flow. The harsh systolic ejection murmur at the left upper sternal border is due to the turbulence which is caused across the stenotic right ventricular outflow tract. So this is the best answer as far as this question is concerned. Now, if you look at the another option, that is option number C, patent ductus arteriosus. It may be present, but not the primary cause of cyanosis that is usually seen in case of TOF. And increased pulmonary blood flow. TOF is characterized by reduced pulmonary blood flow instead of increased pulmonary blood flow due to right ventricular obstruction. Now, PDA is a persistent connection in between the pulmonary artery and the aorta due to the failure of ductus arteriosus closure after the birth. We all are aware of this fact. Now, what is the pathophysiological mechanism? You know, the persistence of the ductal blood flow, it results in continuous left to right shunting of the blood from the aorta into the pulmonary artery. Second, it increases the pulmonary blood flow, which results in pulmonary congestion and left atrial as well as ventricular overload. Now, over a period of time, this can cause the features of congestive heart failure like tachypnea, dyspnea, poor feeding, and pulmonary hypertension. And eventually, when the shunt reverses from right to left, then causing cyanosis and clubbing, which is identified as Eisenmenger syndrome, which we have already talked about in case of VSD. But how? How this cyanosis that is happening in patent ductus arteriosus is different from what was seen in case of VSD. Here, the cyanosis appears in the toes, but the upper body remains pink in case of PDA. So, this is the pathophysiological mechanism. As far as the clinical features are concerned, based on the size of this PDA, if the PDA is small, then it will result in classic continuous machinery murmur at the left intraventricular infraclavicular area. That is the only finding. Otherwise, it is asymptomatic in majority of the cases, having normal growth and development. In case of moderate PDA, where the size is in between 1.5 to 3 millimeters, there will be mild exercise tolerance with the frequent respiratory infections and the bounding pulses or the wide pulse pressures. And in same cases, as we have seen in all other cases where there is left to right shunt before the pulmonary hypertensions, it might result in the features of heart failure. But when there is a pulmonary hypertension develops, which results in right to left shunting, that is Eisenmenger syndrome, then there will be a development of the cyanosis, the clubbing, and no murmur due to equalization of the pressures. So hopefully you have understood the clinical features. The murmurs related to the patent ductus arteriosus we have already talked about, that there will be a continuous machinery murmur which is best heard at the left infraclavicular area along with the bounding pulses and widened pulse pressure. These are the specific findings for PDA. As far as X-rays are concerned, there will be cardiomegaly and there will be a prominent pulmonary artery. Now, the question related to PDA is that a 4-month-old infant is brought to the clinic for evaluation of poor weight gain and frequent respiratory tract infections. On examination, the infant has bounding pulses and a continuous machinery like murmur, best heard at the left infraclavicular area. By looking at what is being provided to you in the question, you have made the diagnosis of patent ductus arteriosus. But here they are not asking about the diagnosis, they are asking what is the pathophysiological mechanism behind this. And if you go option to option wise, like right to left shunting leading to cyanosis, this occurs in the conditions like Fallot's tetralogy or when a PDA develops Eisenmenger syndrome. You know, in a uncomplicated patent ductus arteriosus, the shunt still remains left to right. So it causes pulmonary overcirculation but no cyanosis. So early cyanosis is the feature of TOF, not in this case. Second, If you go with the option number two, the pulmonary blood flow in case of PDA, the blood flows from the high pressure aorta to the low pressure pulmonary artery. That means left to right shunting is seen in case of PDA. This increases the pulmonary blood flow, causing pulmonary congestion and volume overload. So classically, it manifests as frequent respiratory infections, poor weight gain, and the signs of heart failure. So, what are the key clinical features on the basis of which you have identified is the presence of machinery-like murmur and the bounding pulses. Failure to thrive and recurrent respiratory infections are due to pulmonary congestion. So, best answer for this is obviously B. That means there is left to right shunting leading to pulmonary overcirculation. In order to rule out the other options, in case of C, where the right ventricular overflow obstruction reducing pulmonary blood flow. Now, PDA does not obstruct the right ventricular outflow, remember. Instead, it is responsible for increasing the pulmonary blood flow. So, this obviously is not the correct answer. And finally, decreased systemic vascular resistance leading to hypotension. In PDA, it does not cause systemic vasodilatation or hypotension. Instead, the left to right shunt increases the pulmonary circulation, leading to congestive heart failure in severe cases. So, this option is also ruled out. So, from the question, you have to identify the diagnosis, and among the options, you have to identify the pathophysiological mechanism behind that diagnosis. And then finally is the atrial septal defect. ASD is an abnormal opening in the interatrial septum, which is responsible for allowing the left to right shunting of the blood. So, this left to right shunting of the blood occurs because the left atrium obviously is having a higher pressure compared to the right atrium, and this oxygenated blood from left atrium enters the right atrium. So left to right shunting is present. Over a period of time, what happens, this increased right atrial and right ventricular volume, it leads to right atrial and right ventricular dilatation, and increased pulmonary blood flow, it results in pulmonary overcirculation. So late onset pulmonary hypertension and Eisenmenger syndromes are developed based on the pathophysiological mechanisms that we have already talked about. One important thing related to the ASD is that it is also associated with paradoxical embolism risk, which is that if the right to left shunt develops, that venous thrombi can bypass the lung and cause a stroke or systemic embolism. So coming on to the clinical features of the atrial septal defect, again, it is based on the identification of the size. If the size is less than 5 millimeters, then the patients are asymptomatic. Incidental murmur detection on examination with a wide fixed split of S2. While in case of moderate ASD, there will be features of the congestive cardiac failure, frequent respiratory infections, dyspnea, soft systolic ejection fraction murmur, right ventricle heave due to volume overload. But if it becomes large, the defect becomes large, more than 10 millimeters, then before the development of the pulmonary hypertension and after the development of the pulmonary hypertension, the features remains the same. Remember, after the development of the pulmonary hypertension, there will be no murmur because of the equalization of the pressures. So hopefully you have understood everything related to the clinical features of this. Also, in case of ASD, the typical murmur findings are wide fixed splitting of S2, which is best heard at the left upper sternal border. Coming on to the X-ray findings, the right atrial and the right ventricular enlargement is there with the increased pulmonary blood flow. These are the features on the X-rays related to ASD. But more importantly is the confirmatory question. A 5-year-old child is brought to clinic for evaluation of easy fatigability and frequent respiratory infections. On examination, the child has a wide fixed split of second heart sound and a soft systolic ejection murmur at the left sternal border. So you have identified that the question is asked in relation to the atrial septal defect based on the findings which are provided. Now, there are no signs of cyanosis. What is the most likely underlying pathophysiological mechanism? As you know, once you have identified it to be a feature of ASD, so what are the clinical features which are provided over here? There is a wide fixed split of second heart sound, which is wide because of prolonged right ventricular systole, which is happening because of the volume overload. And why is it fixed? Because it does not change with respiration due to constant left to right shunting. Other finding is soft systolic ejection murmur at the left upper sternal border due to increased pulmonary blood flow through pulmonary wall. Then another finding is mid-diastolic murmur at the left lower sternal border. And no cyanosis unless the Eisenmenger syndromes it develops. Now let's see how the question on ASD are asked. Like a 5-year-old child is brought to the clinic for evaluation of easy fatigability and frequent respiratory tract infection. On examination, the child has a wide fixed split of second heart sound. Why is it wide? Because of the prolonged right ventricular systole from volume overload. Then why is it fixed? Because it does not change with respiration due to constant left to right shunting. So you came to understand that the question is asked from the topic, that is atrial septal defect. Then, if you further read the question, there is a soft systolic ejection murmur at the left upper sternal border, which is due to increased pulmonary blood flow through the pulmonary wall. So, all these features are suggestive of atrial septal defect. Now, what is the most likely underlying pathophysiological mechanism? We have just seen that if we go option wise, like right to left shunting causes cyanosis. In an uncomplicated ASD, the shunt is left to right, leading to increased pulmonary blood flow, and there is no cyanosis, which is mentioned in the question. So obviously, this option is ruled out. Left to right shunting causes right ventricular volume overload. This is the correct answer for this particular question because it is a basic pathophysiological mechanism behind the atrial septal defect. Now, obstruction of the right ventricle outflow leading to decreased pulmonary blood flow. You see, there is no obstruction in ASD. Instead, there is increased pulmonary blood flow rather than decreased pulmonary blood flow. So, this option is also incorrect. And then finally, the increased systemic vascular resistance causing left ventricular hypertrophy. You see, ASD does not increase the systemic vascular resistance. Instead, it is responsible for increasing the pulmonary circulation and right heart workload. So, this option is also ruled out. The best answer for this is basically the pathophysiological mechanism behind the earlier features of atrial septal defect. Hopefully, the session was of help to some extent. All the best for your future examination. In case you do not want to miss any update, please join our Telegram group. The link is provided to you in the description. All the best.